Hello friends, this is Dr. Sunil Kumar Ahuja. Welcome back to Brain and Disease Corner. Today I will be teaching you post-ictal psychosis. So let us begin. In post-ictal psychosis, as the name suggests, there is a psychosis which occurs after the seizure activity, but it does not immediately follows the seizure activity. There is a lucid interval between the termination of seizure activity and onset of the psychosis. So first there is a seizure activity, then post-ictal confusion or lethargy, then lucid interval, and then the development of the psychosis. In this lucid interval, there is a return of normal mental function. That is, in this lucid interval, patient is awake, alert, and oriented. In most of the cases, this lucid interval lasts for the 2 hours to the 72 hours, but in some cases, it may extend up to the 1 week. Good thing about this post-ictal psychosis is that this is a brief and self-limited. That is, in most of the cases, it lasts for the 1 week, but in some cases, it may extend up to the 3 months, and it remains on its own. But in post-ictal psychosis, there is agitation, aggression, and psychotic symptoms. Usually, we control these symptoms through benzodiazepines and or typical or atypical antipsychotics. In most of the cases, there is a typical history of the 5 to 15 years history of the drug non-responsive or poorly controlled seizures, and there is a flurry of the seizure just immediately before the development of the psychosis. Now coming to the risk factors, there are the various risk factors have been reported. Among them are the first one is the history of the long-standing seizures. There is a gap of 5 to 15 years between the first episode of the seizure and first episode of the post-ictal psychosis. That's why post-ictal psychosis is usually seen in adult population. Second one is the recent exacerbation or increase in the frequency of seizures. Third one is the status epilepticus. Fourth one is the poorly controlled or drug non-responsive seizures. Fifth one is the generalized tonic-clonic seizures, which may be idiopathic or secondary to complex partial seizures, especially of the temporal lobe origin. Sixth one is the widespread cerebral lesions, which are suggested by the past history of the encephalitis, head injury, low IQ, or interictal epileptiform discharges like sharp waves, spikes, or slow waves. Seventh one is the family history of the schizophrenia or manic psychosis or other psychiatric disorders. Eighth one is the focal cortical dysplasias. Ninth one is the psychic auras. Age and genders are not appear to be a significant risk factors for post-ictal psychosis. Now coming to the clinical presentation of post-ictal psychosis. Post-ictal psychosis is present as a three forms. First one is the pure pleomorphic psychosis. Second one is the pleomorphic psychosis mixed with the delirium or confusion. And third one is the delirium or confusion. The most common presentation is the pleomorphic psychosis, but many patients also present with the pleomorphic psychosis mixed with the delirium or confusion. In pleomorphic psychosis, patient has the mixture of the psychosis, mood symptoms, and agitation or aggression. In psychosis, patient has the various kinds of delusions, hallucinations, disorganized speech, disorganized behavior, or catatonic symptoms. In delusions, patient has the somatic delusions, religious delusions, grandiose delusions, referential delusions, and or persecutory delusions, and various others. In hallucination, patient has the auditory, visual, and various other hallucinations. In mood symptoms, patient may have the depressive symptoms or manic symptoms. During the agitation or aggression, patient may self-harm or may harm to the others. Now coming to the EEG during post-ictal psychosis. EEG during post-ictal psychosis shows increase in the interictal epileptiform discharges like sharp waves, spikes, or slow waves, especially in the temporal lobe. But many patients also present with the normal surface EEG or EEG suppression. Now coming to the etiology and pathophysiology of post-ictal psychosis. Although exact etiology and pathophysiology of post-ictal psychosis is not known, but it is assumed that post-ictal psychosis is the result of cumulative effects of long-standing seizures. Various SPECT studies have reported that there is increase in the blood flow or metabolism during post-ictal psychosis in frontal lobe, temporal lobe, and basal ganglia, especially the left basal ganglia and the right temporal lobe. That's why psychic thought paralysis as a causative agent of the post-ictal psychosis was rejected because in psychic thought paralysis there is a decrease in the blood flow or hypoperfusion was seen. Now coming to the treatment of post-ictal psychosis. As we know that the post-ictal psychosis is the brief and self-limiting, but we also know that the post-ictal psychosis is present as a psychosis, mood symptoms and agitation or aggression. So to prevent the harm to oneself or to the society, we give the drug. To control the agitation or aggression, we prefer the benzodiazepines, and to control the psychotic presentation, we give the antipsychotics, either typical or atypical, in low dose. For example, risperidone 2 to 3 milligram, they may be given maximally up to the 4 milligram. If these drugs are given during the initial phase of the post-ictal psychosis, that is during the prodromal symptoms like the anxiety or insomnia, then they are given for the 2 to 5 days. But when patient presents with the full-blown picture of the post-ictal psychosis, then these drugs are given for the 6 months. This is all about the post-ictal psychosis. Still, if you have any query, please comment on the comment box. I will try to solve it. Thank you so much for watching this video.